thank you very much for the invitation to speak here. It's a particular pleasure and very prestigious to be a Women in MS special edition of this conference. So I'm speaking, as you've heard, on cognitive dysfunction in progressive MS and how to manage it. So here are my disclosures. And so my plan is, I'm going to say a little bit about cognition in progressive MS. I'm going to discuss what our management options are in terms of cognitive rehabilitation and physical activity. I'll just briefly mention some of the studies that are currently underway and I think will give us some very important results. And then at the very end, I'm going to pull together my thoughts on how perhaps we should be approaching progressive cognition. So firstly then, what do we know about cognition in progressive MS? Well, it will probably be well known to most of you in the room that the pattern of cognitive deficits in MS is fairly well established, and all large group studies show that memory and information processing speed are the most affected, problem solving and visual spatial abilities are the next most affected, and language and simple attention usually intact. And if we look at how these different types of cognitive abilities are affected in the different disease groups, this is the Rao battery, and for those of you who don't know the Rao battery, I'll help you through. So here's the relapsing remitting group. These are all matched, and the impairment is calculated against a matched normal control sample. They're all from the same part of Greece. So you can see, if we look at the relapsing remitting group, this is the percentage impaired. And if we think about maybe 25% as the cut-off for we would start being worried about how many were impaired. It's only the visual memory and the, of course, the SDMT, that sentinel test, which are showing significant prevalence of impairment. Then we look at primary progressive MS and things start to move up very sharply. And here we've got visual memory, SDMT, information processing speed and verbal fluency all rocketing up. In secondary progressive MS, there is a similar pattern of prevalence of difficulties in these areas. And then just for comparison, the CIS group, much less expectedly. And you can see it's only the visual memory test that pings up as being affected. So this is a pretty fair representation of what's been found over the years in terms of the different phenotypes. There are a number of papers which show subtle differences, and here we're talking about progressive MS between, for example, primary and secondary progressive MS, but there's no consistent finding. There's no consensus that they have a different profile to the basic story that I'm showing you here. And interestingly, this is a study which asked people with primary progressive MS how cognition affected their quality of life, and it looking at these patterns of correlations just to pull it out. So here's the SF-36, a quality of life measure. You can see that all of the cognitive tests are the ones that are really feeding into the quality of life measure in this group of primary progressive patients, whereas the more physical measures have a very indirect and weak link to health-related quality of life. So it's very important for people with progressive MS that we tackle cognition in an effective and sympathetic way. So what happens over time? Well, this is a 5-year follow-up study from the Amsterdam group looking at what the change is in cognitive change over 5 years. And here are our healthy controls. And you'll see there's quite a lot of variability even in healthy controls. Here is the whole group of MS patients. And then if we look at relapsing remitting, again, there's a huge range over the 5 years. But when we look at the secondary progressive and the primary progressive, you can see that the majority of them are starting to slide down the scale. Again, there's a range. Some people are actually better after 5 years, but the majority are sliding down the scale. And this is, I think, well known, but just to briefly remind you, there is an accepted pattern of fMRI activation relating to cognition, which has been tied into the different phenotypes. This happens to be a study of working memory from Milan. It could have been any one of 100 experiments. And so you'll remember that here we have the healthy controls showing their working memory activation. For the cis patients, there's a little bit more activation, but mainly it's just an increased activation level. By the time we get to relapsing remitting MS, there's not only increased activation, but more areas are recruited, and this has been characterized as plasticity, which is maintaining cognitive function or trying to. And by the time you get to secondary progressive MS, there's a marked fallback in activation for the same task. And there's a corresponding deactivation pattern. So this has led people to develop a model of how the neural underpinnings of cognition might explain cognitive impairment once cognitive performance starts to decline. And this is a fairly classical Schoenheim cartoon. And the story is that as structural damage increases, the network efficiency manages to hold on through plasticity and increased connectivity, which paradoxically eventually becomes a problem. And at some stage, at the onset of cognitive impairment, the network efficiency drops off and the cognitive dysfunction has the mirror exponential and starts rising. So that's our best understanding at the moment of what explains cognitive impairment. I'd make a couple of points. The first is that this doesn't necessarily mean it's secondary progressive, because secondary progressive is clearly tied to physical function, and people may reach this point of cognitive impairment, marked cognitive impairment, either before or after they reach their diagnosis of secondary progressive. But just for the moment, if we were to think of that broadly as the secondary progressive point, we all know that not all patients with secondary progressive MS get a bad cognitive impairment early or at that diagnosis time. And there are a couple of things that I think are useful for us to just think about when we try and work out why that is. So just to summarize, the neural networks that underpin cognition become more disorganized. There's excessive and more widespread recruitment in secondary progressive MS, which indicates a failure of brain compensatory mechanisms, translates into greater cognitive dysfunction. The resting state fMRI, interestingly, shows dysfunction in anterior components of the default mode network, which is associated with more cognitive decline. So why does cognition fail in some secondary progressive patients and not others? Well, the first thing I think feeds into that is cognitive reserve. And this is Simowski's paper from Neurology. It's a randomized control trial which followed patients over 4 years in the North American health system. And you can see the people starting with the high cognitive reserve lost less, people with medium cognitive reserve lost less slightly, people with less cognitive reserve lost more function. And this was true for information processing speed and memory, which are, as we know, the two most prevalent difficulties for people with MS in the cognitive area. So we are very interested in intellectual enrichment, and I'll talk a bit more about that later. But because people have different levels of cognitive reserve, and there's all kinds of markers for that, what kind of job you do, what kind of education you've had, that means that when MS arrives in the patient's CNS, not all patients are equally vulnerable to cognitive impairment. And the other issue, which we're only just starting to understand, is aging. And this is some data from Ralph Benedict's unit, which looks at information processing speed, top 2 tests, verbal memory and visual memory. And the red line is the healthy controls, and the blue line is the people with MS at various ages. And it's been argued from this and other data that actually what we're seeing when we look at people with MS who have cognitive impairment is actually an advanced aging, and that the aging story is really explaining what's happening to them. Now, it's not properly thought out yet, but there's clearly a confound between aging and secondary progressive MS, and so we need to bear that in mind when we're trying to understand cognition and measure it with normative data. So now I'd like to talk a little bit about management options. So cognitive rehabilitation is important, but actually the first stage is really monitoring. So I would argue that early and ongoing cognitive screening could identify patients who are at risk of income or job loss. So potential accommodations could be implemented in the workplace. And here, if they're being considered for security or insurance, that all matters. Deficits that interfere with driving and inform necessary accommodations to improve safety. And individuals who have difficulties with self-care, treatment adherence and medical decision-making, thereby enabling providers to tailor patient interactions. And we know there is evidence that people with progressive MS have particular difficulty with, for example, financial calculations and understanding. There's validated tests of that. And also medical decision-making, there's validated tests of that. And these combinations of difficulties in information processing speed, memory, and these other factors, as they start to get more severe and they start to stack up in the different domains, sort of coalesce into a perfect storm such that people can no longer negotiate these very difficult life tasks. So cognitive rehabilitation in MS in general has been described, and it's probably fair to say, as therapeutic services designed to improve cognitive functioning and participation in activities affected by cognitive impairment. And typically in the clinic, they're part of a multidisciplinary comprehensive program. And it would start with cognitive assessment, there'd be project planning, there'd be specific interventions and training, and then there'd be monitoring of efficacy, tolerability and adherence. And that would be very individually tailored to the individual patient's needs and possibly also to the prejudices of the unit that they found themselves being treated on. So there has been a systematic review from the Kessler unit of cognitive rehabilitation covering 2007 to 2016, and they found 59 articles that fitted their criteria, 6 class 1 evidence, 10 class 2 evidence, 24 class 3 evidence. But the majority of these studies included no or only a fraction of progressive patients. So I'm not going to review those today because if they've only got 1 or 2 progressive patients, I'm not sure it really informs our discussion here. Interestingly, a number of those studies have been used for guidelines and professional practice work. But there were 2 within the 59 that did include a significant proportion of progressive patients. So I'm just going to briefly run through those, and we might find ourselves disappointed. So the first one is Carr et al. It's a randomized control trial of group memory rehab, and it was designed to assess the feasibility and effectiveness of a group memory rehab program. And the recruitment criterion was people with MS had to have self-reported memory problems. Now, it's well established in the literature that the self-reported cognition is very heavily confounded by a number of psychosocial factors, not least depression. And so that is a problem in terms of the methodology. However, here we have our breakdown, and you can see that we've got about half progressive in the intervention group. Obviously, they're randomized, and about similarly half progressive in the control group. And the treatment group had 10 1.5-hour sessions and homework over 10 weeks. And the components were both restitution, where they give people internal memory strategies and errorless learning, and compensation strategies, external memory aids. And the control group was an active control, so that's a good methodology, relaxation techniques and coping strategies. But they only had self-report outcomes, and I've already mentioned that they are problematic. And on the everyday memory questionnaire, there were no significant differences, but they did show a significant effect, improvement in depression in the rehabilitation group. So that's not really the basis for implementing that in the clinic. And the second study is Hansen et al., where they were looking at a more broader cognitive rehabilitation in MS. And they looked at the effects of cognitive rehabilitation on cognitive and executive coping, psychological well-being, psychological aspects of health-related quality of life. And they were participants at a multidisciplinary inpatient rehab program, again recruited on the basis of their subjective cognitive complaints Interestingly, they did then put everyone they recruited through a very lengthy neuropsychological battery, but they didn't use that to recruit them. And crucially, they didn't use it to assess their outcomes. So that's a rather strange way of approaching cognitive rehab. So just to show you, you can see that, again, about 50% relapsing, 50% progressive in the two groups. And the treatment groups, this is fairly standard rehab program, cognitive strengths and symptoms, general advice for coping, and 3 2-hour targeted sessions looking at more specific issues and strategies. And these are self-report. If we look at the control group, baseline 4 months, 7 months, there were some improvements in self-reported executive function. And if you look at the intervention group, there was something very similar. So overall, there wasn't a great deal of difference. However, there is now an increasing interest in exercise and cognition. And I was involved with a project with the Valens group, and these are the results here. And we compared high-intensity training, high-interval training with ordinary exercise in the rehab program. So it was a very strong methodology. And just to draw your attention to the top half here, verbal memory did improve in the high-intensity group, and also the errors on an attentional task went down. So that's also an improvement. And there have been other studies which have shown this when they've compared exercise with weightless control, no control. But the strength of this methodology is that we compared high-interval training with the normal exercise that people would have in a rehab unit. And we were half progressive and half relapsing remitting, so it was okay to include it in my criteria for the lecture. So what studies are underway? Well, we're following up our exercise program with a 2-arm single-blind RCT, and we're going to be looking at some biomarkers as well as cognitive performance to try and untangle what would be happening and how that would, what underpins the changes that we're seeing. Perhaps slightly more interesting, though, is the CogX trial, which is currently underway and is being led by Anthony Feinstein. It's been funded by the Canadian MS Society, and the title is Improving Cognition in People with Progressive Multiple Sclerosis Using Aerobic Exercise and Cognitive Rehabilitation. And they have 6 countries involved, and they have 4 groups. So one group has sham exercise and real cognitive rehabilitation. It's actually the RehaCom, which is a really well established and has a lot of literature support in improving cognition in MS. And then there's all the alternatives. So there's sham cognitive rehabilitation and real exercise, sham cognitive rehabilitation and sham exercise, and real cognitive rehabilitation and real exercise. And it's powered to disentangle those 4 things and work out what the most sensible intervention is for progressive patients. So that's very exciting, and we're very much looking forward to seeing those results in a year or 2. So now I'd like to take some time to talk about my management plan that I'd like to suggest to you. When we're thinking about people with progressive MS and their cognitive issues, really managing that starts right at diagnosis. And I would say that it's a good idea for the clinic to follow a brain health agenda from the earliest possible stage. And all of those things that you know affect physical progression in MS, all of those lifestyle things like obesity, exercise, alcohol, smoking, all of those things, they have also been shown to affect people's rate of progression of cognitive impairment. So they work for that too. And in addition, for cognitive impairment, it's also very likely that giving people some kind of stretch mentally, something which challenges them mentally, is also going to be protective. And for that, I would say just as a quick guide, reading a book, good. Joining a group that talks about a book, better. But writing a short story, best. So you want to try and push your patients, or get your MDT to push your patients to be doing something that pushes them into something that sort of stretches them intellectually. And I would recommend that you start that as soon as they're diagnosed, and you review it every year, and help them, support them to have a schedule which helps them design and manage their lifestyle to reduce both their disability progression and their cognitive progression, because it's something they can do. And actually, by the time someone comes to you with a cognitive crisis, a lot of function and ability and potential has been lost. So that's why I would like to suggest to you, you should start early. And not in MS, we don't have good data on interventions in MS. We have survey reports from people saying they're doing this stuff, and they're the ones who have the least cognitive impairment. But there was a paper in Neurology this year where MCI patients were given a lifestyle prescription, and it was a randomized control trial, and the ones given a lifestyle prescription looking at these things did actually do better in terms of not progressing to full Alzheimer's. So I would really recommend that. Of course, it's important that there's effective DMD management of the disease. Of course, it's important that there's effective management of comorbidities. So as well as all the other things that are happening for them, so their cardiovascular status, their diabetes, their vaccinations to make sure that they're avoiding insults to their immune system that can be avoided. The other issue about effective management of comorbidities is not prescribing things for symptomatic management, which would give a cognitive impairment, would reduce their cognitive abilities. So there we'd be thinking about anticholinergics and things like that. So it's very important that the comorbidities are managed from both a positive and a negative perspective. I would really recommend annual monitoring of cognition, and there are 30 papers in the last few years from experts in the field saying that annual monitoring is very important, so all these things can be implemented and patients can be reminded. And when significant cognitive impairment is identified, firstly, amend clinic interactions to compensate. We know there's good evidence that people with MS with cognitive impairment are much worse at symptomatic management. So just to pick a paper at random, for example, urinary function. So, just by these few simple steps, if you can avoid one admission for a urinary infection, then you've got your money back, haven't you, see, I would say. You can increase monitoring for risks. We know that people with cognitive impairment with MS will have increased risk of falls, they will have increased risk of driving accidents, they will have increased risk of poor adherence to medication. So for all those reasons, those things need to be monitored more carefully, maybe structures put in place to take account of those. And then also you can think about a structured cognitive intervention. Now, if you have a multidisciplinary team, you can have a full assessment with your OT and your physio and your psychologist, whatever is needed to support, say they've got an information processing speed deficit. Every single one in the MDT, when they're interacting with them, can take account of that. The family can be educated and encouraged to communicate with the person more effectively. The person can be given strategies which they can use. There is a lot of evidence that the cognitive rehabilitation in the computerized training works very well for people with relapsing remitting MS, and I would argue that when somebody gets to physical secondary progressive MS may not be the time they get to progressive cognitive MS, and therefore I would say that that evidence is probably of note to us trying to decide what we do. And we do know, for example, looking at the relapsing remitting data on cognitive retraining and cognitive rehabilitation, there's very strong evidence, for example, Kessler Foundation's paper of Class 1 evidence in neurology, that if you give people a very structured program, if you really drill them and train them and make them go over it and over it, you can actually make big differences in how well they're able to manage their lives, interact with their family, maybe hold on to their job. There's lots of evidence that by making small accommodations to work situations, people can become much more functional. So in the early stages, even small things like moving someone to the corner of an office when they're in the middle of a busy office with their information processing speed and distractibility problems can just make all the difference. And by picking these things up early, by helping people understand that it's their MS and their cognition that's interacting with their employment ability, you can make sure that they get absolutely the best out of their life and their opportunities. So I think on that note, I'll say thank you very much, and that's the end of my talk.